So setup before procedures is pretty important too. If you're using the ultrasound, I'm in my mind doing how I normally would, but I want you guys to be able to see as much as possible as well. So I'm going to be doing, we got an EMG a couple months ago, a month ago, that showed slowing of the ulnar nerve at the cubital tunnel here. So I'm going to be doing a hydrodissection of that ulnar nerve. And then he has some wrist joint arthritis, so I'll be doing an injection into his wrist joint as well. So I'll go dorsal with the wrist joint, obviously with here. You need the patient to be comfortable, so you can have them lying like on his left side and just like this, or you can have it above the head. Obviously, if they have a lot of shoulder pathology, it's hard for them to keep it up like this, but I just tested that, and he's all right. So, so I'm basically going to have him with his left, yeah, exactly like this, and then I have a good view. The other thing is take care of yourself as well. You know, you don't want to be doing a procedure where you're injecting like this and constantly looking and straining your neck. So I always like to be right in line with the ultrasound. You know, a lot of my practices, I have a TV screen for the patient and the ultrasound, so there's one each way, so you can always have, you know, one direction to look at. And that's a pretty cool setup, because then the patient is actually seeing, you know, what's going on while you're doing it, and you can kind of explain everything to them. So that's not a marketing thing because they're already there, but that's a patient satisfaction thing that they really enjoy, being able to see their own pathology for diagnosis, but then also for the procedures. All right, and so I usually do a little numbing for all my injections. Again, for the wrist joint, I'm not going to go into the joint with the numbing. I'm just going to do superficial soft tissue. For the elbow, or for the ulnar nerve, you know, it's not going to matter as much if there's no joint. I'm not going into the joint. And I've done a lot of these just with saline as well, with a little bit of lidocaine. As far as a hydrodissection, do you guys know what a hydrodissection is, or anyone not know that you want me to kind of explain? I'll just explain. But basically, there's areas where the nerves kind of get pinched, and we're trying to peel the layers off of it, you know, without hitting the actual nerve, to give it more space to operate in. So, you know, I do it here, you know, some around the ankle. Most common is the carpal tunnel as well, just trying to give that more space.
What are his symptoms?
So he's got numbness tingling in the 4th and 5th, and then with both flexion and extension, wrist pain. Yeah. And then we got x-rays of the wrist, confirmed that he has arthritis, and then the EMG to confirm he has, I think it was mild to moderate ulnar neuropathy.
The volume of injecting, what you typically use as your injecting for like a carpal tunnel?
So for mild to moderate, I can just use basically saline with some numbing, just lidocaine and saline. So it's more of a structural thing.
Yes,
I used to put some in there, but more. When I do it now, it's more nano doses instead of, you know, actually like 4 milligrams or 8 milligrams of dexamethasone.
I've heard some people using like 25 cc's of the carpal tunnel. It's like, that sounds like a lot.
Yeah, at the most I'll do is 10 usually, where, you know, because you're going over it, under it, and I do 2 injections, you know, 2 pokes, I guess, over the nerve, under the nerve, and then I go along the top of it. Obviously, when you're going this way, you can't go under it, or you have to go through the nerve to get there. So, you know, I usually use about, the most I would use would be 15, like doing 10 this way and then 5 the other way, but they're going to be all blown up. So usually 10 total combined for that. Yes.
You know, I just want to ask you, do you find that the results are age dependent on the quality of the exosomes and the PRP? work as well as, let's say, a 70-year-old, an 80-year-old, a 30-year-old?
Yeah, so I was in Tucson, Arizona, so it was a huge retirement community there, so I had my young athlete population, and then I had 70, 80, 90-year-olds, and tracked all the results with Data Biologics and another company called Gray Ledge, and no, there was not a significant difference based on age. But that's the thing, if reps talk to you and trying to get you the exosomes or whatnot, they're gonna say, that guy's cells are too old, they're not working, you have to get the baby cells. That's just their sales technique, okay? Okay. You ready?
For the light on or off?
No, it's fine, off. I'm just gonna grab a little solution. So you can use sterile ultrasound gel, but I prefer, it's basically a mix of hibiclines and isopropyl alcohol. So it cleanses the area, but it also acts as the ultrasound medium too, so you don't have to use the sterile gel. If you're doing, a bony place where you need a step off, which means, like if I was trying to inject here and you can't really see because of the angle, then you have to put sterile ultrasound gel to get in that way. But anywhere flat, you'll see this works very, very well. So again, this doesn't have to be, I'm using sterile gloves, but this is not a completely sterile procedure. The little one. Is your arm asleep yet?
No, but I did have a couple jokes.
All right. Yeah, no, the mic's yours now. You're
You
on the
called me
spot.
old.
Oh, is that what you're saying? Is that what you're implying?
Not you.
Yeah.
So I usually use, like I could have a spray bottle full of this stuff. I just call it the pink stuff, but obviously it's what the hibiclins, isopropyl alcohol, or just pour it onto a 4x4. All
I
right.
just writes it down this way and
You
I'll
did?
look at this one.
Okay.
That was the only way I could-
I have hackers for the money, but I also found a 1-inch. You never have a 1-inch out.
Uh-huh.
So that was fine.
All right, and then can you do, I always turn the Doppler on just to make sure there's not a blood vessel. And then to the right as well, please. All right. So we're good as far as the All right, so you can see my target right in the middle of the screen there. It's a little clearer here, but so that's what I'm trying to hydrodissect right there is that. Thank you. All right, so I'm just doing a little soft tissue numbing. We're good. You don't need it. You don't need to do that. Oh,
Sorry, should have warned you.
that's-
For the, oh, for the, 30 or 95, just need to.
I'm just going to do some talking for Dr. Wall. So you can see the approach that he's using, he's actually injected before he gets to the nerve, to make sure that you actually don't do an intraneural injection. So as you can see, he's kind of creating that wheel. It also kind of allows you to see the other structures going on, so that's a very important technique that he's using right there. The other thing Dr. Dewald was pointing out, the fact that, he's going after the ulnar nerve. You can actually see, his actual circular shape. You can see here he's likely having some more chronic nerve issues because you're not seeing that great honeycomb pattern. Now, a lot of times you'll see in the nerves, you can already tell that he already has some issues here. So his brain's already in auto mode. So
Yes. Alright.
but he brought up another very good point to make sure that you always use a color Doppler to make sure. Sometimes you just have these aberrant blood vessels that should not be where you think they shouldn't, and that's how you get yourself into trouble. So I'm always checking out for that. But like I said, it's very important, like I said, the technique he used with his needle, particularly if I'm using just a little bit of anesthetic, I'm just injecting just a little bit just to kind of see how the tissue reacts. Is the tissue going to push forward? Which way is my needle going? Is the bevel up or down? All those little things really, really matter when you're doing these very small details. You're trying to make sure you're going to maximize your outcomes. So these are all.
You can also use the EPP, so you can use that. We use that a lot in terms of if you want an alternative to the anesthetic or steroid.
Your PDP is definitely a good option because you're going to probably throw it out anyway. So why not put it to use? So Dr. Garber has a very good point.
It is hard to see.
You want the lights on?
No, that's alright. Once I get it in, then.
I feel like,
So,
Yeah,
Alright,
watch it.
another poke here. Alright. No, once I'm in, I'm good.
So as he's going in, he's doing cross-sectional to the nerve. He's going in plane to the actual probe. So that's the reason why you can see his needle going all the way across.
And then you want to hit it a little bit. There's a little air in there.
So for somebody that don't do a lot of ultrasound guided injections, Dr. Dewald is doing a very important technique when you're just kind of wiping, going back and forth, as opposed to taking his needle out and going in a totally different direction. He's just kind of looking to see where his needle is, get himself comfortable going into going towards his target.
Alright, now you see those layers kind of getting peeled off. Alright. How you feeling?
Great.
You guys see now he's going to undersurface portion of that ulnar nerve now. He's working his way around there. Just doing a little bit of hydrodissection as he continues to inject. So he's there. Nerve there.
This is a pretty high density probe, correct? Or do you know? Okay. Yeah, so the higher quality image you get, the less, well, I'm also using a 25 gauge needle. But that's why it's not super apparent at every angle, but you can see the needle very well right now. So you just kind of go, inject, go a little more, and just kind of carve that out. And then I'm going to retract and go above the nerve now. Yeah, I might need to switch it up a little bit.
So it's very important to remember that relationship between the frequency and how far you're going down. The higher your frequency, you use for more superficial structures because it just allows for better resolution. If you have to go a little deeper, depending on the patient's body habits, sometimes you might have to adjust the frequency just to go a little bit lower, particularly if it's your first time like doing these, just so you can have a much better visualization of where your needle is going.
Zing.
So you can see as you're tracking this needle, you're ready to go a little more superficial to the nerve now. Same technique as we were using before. Inject before you get there. Creating a nice little halo we got going on right here.
One is done. All right, so you can see how much did I inject? I probably injected about 5 cc's of fluid in there. And that really, for this, about 5 cc's.
Oh, no, that's just saline.
No, this I actually did PRP, so I'm out. Like I said, if it's mild to moderate, or at least mild, I can just use saline, for the severe, and I'm talking carpal tunnel, then I really go for the PRP for that.
Was this your SuperShot or this was not SuperShot?
This was PRP super, so it's all the same, just as far, I was gonna just do plasma here and then the rest there, but we had enough, so he got a super treatment. More than he needed. There you go.
Yeah, yeah.
What needle do you use? Do you have any concerns for neuritis when you're injecting around the nerve?
Say that one more
So
time.
what?
Do you have any concerns for neuritis when you're injecting around the nerve?
I'll let you go first now.
Yeah, I mean, that's what we're treating is the neuropathy. You're saying if I hit the nerve or?
Well, you're
Come on,
creating
post-
inflammation, right? So-
Yes. But long term, it's really anti-inflammatory. But yeah, when I started doing this, I would do, not a good amount, but like 4 milligrams of dexamethasone and just saline and lidocaine. So it was really anti-inflammatory, but those were not lasting as long as I wanted. So that's why, at least for the severe ones, I do the PRP. But typically, with the with these, as opposed to a tendon, you're not getting that huge flare because it's more potential space instead of going into like the little tears of the tendon. So that's why you don't get that huge reaction.
Yeah, so yeah, I would say I agree with you. When you're going into tendons, you're actually going intratendously. So that's where you have to start worrying about that tendon having a reaction of a flare here. Here, basically, we're trying to inject around that potential space. Most of the time, you might have a mild flare. Typically, it's not as bad. But once again, when we're starting to look at these nerve issues, a lot of times you got to start to look at the tissue around it. The tissue around it will start to get sticky or fibrotic around it as well. So doing these hydrodissections will actually allow that nerve to breathe a little bit. Same thing you think about with surgeon when they go in there and decompress. They're just creating space. And so we're trying to create space in that same fashion. But as well, like I said, we don't always appreciate how some of those tissue layers start to get a little fibrotic around the nerve. So that's what Dr. Dewald is doing by injecting, creating that halo. As you saw, he just didn't go into one plane. He went above it and below it. And at the end, you start to see that kind of like that halo ring kind of go around it. That's what we're looking for going forward. And the same thing he was talking about earlier with regards to carpal tunnel. That's what you want to try to recreate.
You're still with us,
How far from the cubital tunnel?
What does it feel like?
Yeah, so I think it depends on where the patient's symptoms are. Sometimes if you're actually looking at it, and here in this case we only did one spot, sometimes I'll actually inject between the heads of the FCU down there as well to try to make sure I'm getting rid of the most compression as possible, to answer your question. So I'm going, the retrocondylar, I will go there, but I'll also go down there as well. Because I'm basically trying to, if we're talking ulnar nerve, somehow they do an ulnar nerve transposition position, that's what they're doing. So I had to try to recreate that
No,
without opening them up. And so sometimes I have to go into multiple spots to be able to complete that.
How long along the nerve are you going, you know, lengthwise?
So lengthwise, at least, you're talking 2 or 3 centimeters, but
2 or 3 centimeters.
But I'm also not just injecting in one spot. So if I'm injecting up here, that's fine, but I'm also coming down and I would do a second injection down here as well. Yes, is the answer to your question. But it's not just taking a needle and just starting here and just running down. I will actually try to go in both those places. And the reason because I used to do it just all in one spot, but what I started seeing is that I was not just able to get directly where I wanted to go. And so that's where I started creating that second needle poke to make sure that I'm addressing that tissue around in that area. So every patient is not the same. Sometimes you have to adjust your protocol based on what you have going on with your patient. And sometimes it's just more down here as opposed to going to the retrocondylar area. So it just really depends.
And the EMG's most likely not gonna say it's not like an MRI where it's like 2 centimeters below, this bone or whatnot, so you kinda gotta scan up and down and see where it is as well. And like I said, the carpal tunnel I always do in 2 planes like that. With using the PRP, with watching it flow, I'm happy with just doing above and below right there.
What did you inject first in there?
Lidocaine 1% and bicarb, and I would recommend that for anyone that's using lidocaine. Put a little bicarb in. It really takes down the acidity of the lidocaine, so it doesn't hurt as much.
Yes, sir.
Have you noticed instant results with the dissection technique?
Without PRP?
Or just with this technique you just did?
I would say yes. So I have to dissect a lot of nerves. So I have a lot of patients coming for various issues. I end up finding nerves being the issue. Now, it could be some of my backgrounds being physiatrist, maybe. But I have seen definitely a lot of results. Now, the one thing I would tell them, if we're not using orthobiologic, that if I'm just using normal saline or even I'm using just a little bit of steroid, sometimes a second injection is sometimes needed in order for me to kind of complete the job. Now, I'm probably a little more on the concerning end as far as using the amount of fluid, because I hate patients calling the clinic where like, well, the area is big. I'm like, well, it's going to be big for a couple days. So let's say, for instance, in a carpal tunnel, I probably use more like 5 to 6. But if I'm doing like a saphenous nerve, I'll double 20 because I have a lot more space to work with.
Is this being used in lieu of endoscopic carpal tunnel releases?
It really depends on what's going on. So if they start to have atrophy, I'm still going to say, like, those are the type of things I'm still not playing around with. But if it's just more the paresthesias that they're having and they're not having significant weakness, then there's definitely something I would consider.
Would you ever use shockwave to help identify the best spot?
You just walked out of the room because I knew somebody was going to ask that question. Yes is the answer to that question. As soon as the guard comes by, I let him dive in that a little bit further because he's a lot more well versed on that. But yes, this is definitely something you can use.
Alright, so a lot of veins and arteries around the wrist joint, but it all looks good here. Okay. Alright.
So for folks that don't do a lot of ultrasound, try to find the home base. In this case here, we're looking at the bony curvature here. It lets us know that we're likely dealing with a bone. Okay, between 2 bones, you got a joint space. So without going all super academic, that's what you need. Okay. Then the second thing, you want to make sure you got the right joint space. Okay. So that's where your anatomy comes into play. But just for simple, from like an ultrasound anatomy standpoint, this is what we're looking for. Just approximately. Good. Oh, it's already down. Whoop, I was gonna do the whole thing.
I have some sterile travel.
Huh? What is it?
I said it had sterile jaw.
Oh, no. We do color one
little thing I wanna point out is we were looking at the color Doppler, you can see a little osteophyte hanging out right there. So those are little things that you can see as you're starting to do these injections, as you start to come over reverse, you'll start picking up the small things.
And just for your, I'm gonna just move it and just see if we can pick up
That will.
a vein or an artery here, just so you guys know what it would look like. But maybe not.
It's been nice to you today.
You can see a little.
Yes.
I'm talking about the one
Right there.
finger right maybe
Right
there.
down the bottom.
It's going down there, but it should be going to the floor on the top too.
Alright, well, I'm gonna do it.
As he's injecting, other things that I look for, particularly if I'm looking at bony anatomy, on top of the bony contour, sometimes you might see an anechoic or black space. That's what we call the cartilage interface sign. And that basically kind of tells us sometimes about the health of that cartilage. If you have that black, it's typically a little bit more healthy. You start to lose that, that's when you start to get some of those arthritic changes. The reason why you get that, because the ultrasound beam hits against the bone, and then hits up against another tissue, and it kind of sits there, but doesn't know what to quite do with that information, so that's the reason why it's black. As you can see with him, you're starting to see less of that, you start to see some osteophytes that we've seen here in ultrasound, so. I'm not trying to convince you ultrasound is a replacement for looking at x-ray, but when you're doing these procedures, other little things that you can pick up over time that you may not have been looking for before.
Alright, last book here.
You can start to see the tissue disruption on the left side of the screen. You can see his needle coming in. You see everybody be on bullseye. So, for beginners doing ultrasound, sometimes you're not always able to see your needle. Sometimes you have to use that tissue disruption, which basically means that something's moving, right? If it's not the patient, it must be me. And then every time you're not able to kind of inject your product, so you have to kind of trust your anatomy and know where you're going. Or Dr. Dewald's filling up. Dr. Gard, they had a question about using shockwave for nerve issues or nerve disorders.
Yeah, so we use EMTC, actually it's quite good. I'll kind of get into why it's good for nerves.
No, it's okay.
Sure.
Personally, I don't do hydro dissections, I don't know, I like them, so I don't do them, so I send them to people like the others.
It's okay. That's why we're out here.
That's right.
Alright. So you know?
Yeah. Just holding my breath. Just kidding.
Last thing to point out here for more entry-level ultrasonographers, Dr. Wild, he's going long axis to the joint, and he's also going in plane with the ultrasound probe, which basically means that he has to traverse over one set of bones in order to enter that joint space, as opposed to if you're doing it short axis or cross-sectional, then sometimes you can just dump directly into the joint. Now, the issue of going that way is that you don't know how far proximal or distal you're going, but you're able to go directly into the spot by using sometimes a little marker in the middle of the probe. The advantage of going more long axis, you're able to see your needle, and you're actually able to kind of go over the spot, but it does take a little bit more time, a little more patience.
And you also gotta realize there's only so much space in every joint. I probably had a little too much, volume here. So I didn't inject all of it, but I got as much as I could right into that joint.
Yow.
Yeah.
Right, so somebody asked about 25 cc's in that space, that's an astronomical amount. I mean, think about like what he's putting in there, and he doesn't have enough space to put in that regard. So really have a good idea of how much space that whatever you're injecting can hold and be able to go in and out.